Hi, everyone. Welcome and thanks for joining our EGFR Resisters webinar today. We have a special webinar that is focused on Ask the Experts, clinical trials within uncommon EGFR alterations in non-small cell lung cancer. I'm Ivy Elkins, and I'm one of the co-founders of the EGFR Resisters. We'll be joined today by Jill Feldman, another one of the co-founders of the EGFR Resisters, and a couple of knowledge leaders in thoracic oncology. Dr. Julie Rotow is a thoracic oncologist and clinical director of the Lowe Center for Thoracic Oncology at the Dana-Farber Cancer Institute. Her research interests include the development of targeted therapies for the treatment of oncogene-driven lung cancer. We'll also be joined by Dr. Balaz halmos. He currently serves as Associate Director of Clinical Science and Professor of Oncology at the Montefiore Einstein Comprehensive Cancer Center in the Bronx, New York, where he oversees the multidisciplinary thoracic oncology team, as well as the clinical trials office. His research focuses on experimental therapeutics in thoracic malignancies, as well as precision oncology approaches to optimize patient management. Welcome, both Julia and Balaz today. We've decided that we're all going to stay on a first name basis for the purpose of this webinar. And before we get started, I'd also like to mention that today's program was put together by Creative Educational Concepts and is supported by an educational grant from Black Diamond Therapeutics. So again, let's get started. We're glad to have you here. And I'm going to turn the control over to Jill Feldman for our first question.
Thank you, Ivy, and welcome, Balaz and Julia. We're really excited to have you guys here with us today to help talk to our community about the uncommon EGFR mutations. So there are a lot of different ways that we talk about mutations that aren't common in the EGFR community. So we call them uncommon, we hear rare, non-classical, acquired, or atypical. It's very confusing for us to kind of keep up with everything. So how do we best explain to patients what these all mean, that they're all the same, they're talking about the same thing, and what we need to do is help them in a way that they can understand and guide questions that they need to ask their doctors. So we would appreciate your help.
Thanks, Jill, and it's great to be here today. And first, I'll acknowledge even your doctor may not be 100% consistent with how they use this terminology. I think we use some of these interchangeably, but some mean very different things. And they mean different things to your doctor, and they mean different things when it comes to what the optimal treatment strategy might be for your diagnosis. So first, just setting the stage for what is EGFR, what is an EGFR mutation. And the EGFR itself is a protein. It sits on the surface of cells, healthy cells in your body, particularly in skin surfaces, epidermal surfaces, where it usually turns on and off as needed to help maintain cell growth and survival and health. But of course, in EGFR-driven lung cancer, the problem is that there is a mutation in the gene which encodes the protein, the gene that tells your cells how to make this protein, which leads to an abnormal form of EGFR called mutated EGFR. And this causes the protein to get stuck basically in an on position, like a valve stuck open or a light switch stuck on. And that sends too much of a grow and survival signal to the cells and helps them become a cancer cell instead of a healthy cell. So this is just in your lung cells, not in the rest of your body, for example. The most common EGFR mutations we typically treat with something called an EGFR inhibitor. This is a drug that binds to the abnormal EGFR, the EGFR that's in the tumor cells, but not in your healthy cells, and helps to shut down that abnormal signaling. So it turns off the valve, it switches off the light switch, and it stops that survival signaling, so the tumor cells are more likely to die. And we have a number of different EGFR inhibitors these days that that we use when treating patients. We call them a targeted therapy or an EGFR targeted therapy, again, introducing that nomenclature, the terminology we use. But right now, our go-to EGFR inhibitor for these most common EGFR mutations is something called osimertinib. And this is a third-generation inhibitor. And there are other older generations as well, first-generation and second-generation inhibitors that are out there that we used to use that either bound less potently or less selectively or had more side effects. On average, our modern drugs, third-generation inhibitors, they tend to work longer and have fewer side effects, so they're more effective for patients than our older drugs. But of course, we're talking about the common mutations here, and we're going to talk here in this session, what about all the uncommon mutations, and when do we use osimertinib, when do we use other drugs, and when is a clinical trial possibly a good idea? So here's introducing the idea of these different types of EGFR mutations. Now, 85+% of the time, when we say an EGFR mutation, we're talking about these common mutations. And other names for them include classical mutations. Again, we like to switch up our terms here along the way, and we may even do that during this talk accidentally. But these are typically the EGFR exon 19 deletions and EGFR L858R. These are the names for the actual protein changes that make the protein abnormal. These are the most common ones. And this is where a lot of our big clinical trials, if you look at them, they're studying these mutations because they make up the vast majority. But there is a sizable subset, around 5 to 10% of each, of these other less common types of EGFR mutations, the uncommon EGFR mutations. And these may go by other names like rare EGFR mutations or atypical EGFR mutations or non-classical EGFR mutations. And these may have different implications for how effective our various available drugs might be in terms of controlling or treating the cancer. What we're not going to talk a lot about today, but just to put it out there, is the EGFR exon 20 insertions. These are a very different category of EGFR mutations that require very different types of drugs, and they have their own whole set of clinical trials. So they're also very important, but aren't quite the focus of what we'll talk about today. We're really going to dive into these uncommon non-classical EGFR mutations. So here I want to set up the idea of what does it mean to have a driver mutation or an uncommon driver mutation versus resistance mutations. And these are two very different types of changes that require different types of treatment, these driver EGFR mutations. This is the mutation that a doctor might find. They test your tumor at a new diagnosis. It's an intrinsic part of the cancer cells. It's not in your healthy cells and for these mutations. And it's the one they might say, a new diagnosis, we're doing all your profiling of the tumor. We found this mutation. And when you start treatment, that first treatment might be a targeted treatment like an EGFR inhibitor for that mutation. We call them driver mutations because they're present in every tumor cell and they're passed along with every cell as they grow and divide. Each daughter cell contains these mutations. And these might be those common or classical mutations. These might be uncommon mutations, but they're in all the tumor cells. And there's usually just one or sometimes a few in each tumor type. Now, during time on therapy, if you're being treated with an EGFR targeted drug, like osimertinib, for example, the one I mentioned before, that third generation EGFR inhibitor, you're now producing selective pressure. So you're forcing the tumor cells to try to find a way around the drug, and they may evolve effectively to develop new mutations that allow them to survive despite the drug being around. We call these resistance mutations or acquired mutations. Again, we like lots of different terms for what we use for this, but they're all acquired resistance mutations. And these are not necessarily present in all the tumor cells because each little spot of the tumor is trying to find its way around the drug at the same time, and they may find different ways. So these might be present in only some of the cancer cells and again, develop over time on treatment and aren't usually around right at new diagnosis. And there's many different types of acquired resistance mutations. There can be new mutations in EGFR itself that change the shape of the protein such that the drugs we're using can no longer fit in, can no longer bind, like changing the lock in a door. And then there can be other mutations outside of EGFR that lead the tumor cells to no longer care so much about EGFR. We call them bypass pathways, where the tumor finds other ways to get the signal it needs to grow and survive. These are all might be important for selecting therapies. And there's sort of thing we might find at repeat testing on treatment if a tumor, say, was growing on your current therapy. It's very different, but both are relevant and both may have clinical trials that might be of use.
Great. Thank you so much for that description, Julia, of all the different types of EGFR mutations. I think that's very helpful and something that might be confusing to people naturally. So here's a question. You know, many of the members of the EGFR resistors community who have common EGFR mutations have been treated with targeted therapy. But what about for people who have some of these less common, these uncommon mutations? Is there targeted therapy that can treat them as well?
Yeah, that's also a great question. And in some sense, for the more common mutations, we have the luxury of very large clinical trials that tell us, so to speak, what drug might work for the individual mutation. So it's a square peg into a round hole, or a square star-shaped hole, or something else. You know, is it going to line up properly, bind well, and give us an anti-cancer effect that we want? But these uncommon mutations, some are very, very rare, and we know less about what drugs might work best for them. And sometimes that makes it more challenging to pick a drug that we think is going to be the best fit. This is now getting a little more technical, but it's a diagram looking at, if you look at EGFR lung cancer, EGFR mutated lung cancer, and look at what mutations you might find, the blue there in that pie chart are all the more common mutations, or the common mutations with something else, but the common mutation is there. But you see these other uncommon mutations there in red that need their own sorts of treatment. And if you look at them broken down along where they locate in the EGFR protein, you'll see that this is what's called a lollipop plot. There we go, where the little spike each represents an individual type of gene mutation. And the taller the spike, the more common the mutation is. And it's showing different mutations there at the bottom along the EGFR protein, along the different portions of the protein. And I've circled 3 there. They're the 3 kind of most common in the most common of the uncommon mutations in the early series. And I'm going to name them out because I'm going to refer to them later. There's G719, 768, and there's L861Q. Those are the circled ones. They're specific points in the protein where they're most likely to have uncommon mutations. We know the most about these because some of the clinical trials that were originally run with EGFR inhibitors, including some of the older EGFR inhibitors, specifically included these types of mutations. So we know a bit more about them. So I'll talk about them as a model for other uncommon EGFR mutations. So what do we have for these different mutations? And the drug we actually have FDA approved, so you can prescribe it, it's sort of usually covered by insurance, is a drug called afatinib. And this is one of the 2nd generation EGFR inhibitors. So it's a slightly older drug. We don't routinely use it for our more common mutations anymore, because it does carry a little more side effects. It has some downsides, but it was specifically studied for these particular mutations. And because of that, it had positive data. It did have positive data, and it was approved by the FDA. And you can see if you treat people with some of these common, uncommon mutations with afatinib, if you pull the data together, you get about a 71% of the time the tumor shrinks significantly, and on average for about a little over 10 months. And that's what's shown in the chart to the left, where the bars show the best change in the tumor. So the bars are dropping below the midline there. That means the tumor shrank, and if they're above the midline, the tumor grew. And the green bars are the uncommon EGFR mutations. So really focusing on those green bars. This is a bigger study with other stuff in there. You can see that most people with uncommon mutations with afatinib had some decrease in tumor size. And again, about 70% hit that significant decrease. But it does have more side effects. It's got more rash, it's got more diarrhea because it's less selective for the abnormal EGFR, and it's a little less effective for treating brain metastases because it doesn't cross the blood-brain barrier quite as well as newer drugs. So it does have some downsides. So that has led to a lot of question, can you use osimertinib, our usual go-to drug for the more common mutations for these uncommon mutations? And here, that's the question that I think comes up most often in clinic if we're meeting someone with a new diagnosis of EGFR mutated lung cancer with an uncommon mutation, can we use osimertinib for this? Because that drug is often better tolerated. There's usually on average fewer side effects and better activity on average against brain disease. My answer to that question is maybe. It really gets down to the nitty-gritty of what the individual mutation is. And this also gets to the heart of why uncommon mutations are a little more tricky to pick treatment for, because it's really mutation specific. So it has been looked at. They've studied osimertinib for uncommon mutations. I'm highlighting here data from the Unicorn study, which was a study that looked at osimertinib for these uncommon EGFR mutations. And I pulled out the data for two of the ones I mentioned before, G719X and L861Q. And if you look at the response rate column, you can see they're very different. For L861Q, 78% of people had a significant decrease in tumor burden. And for G719X, only 53% did. These are small numbers. It's really hard to, we're stretching a little bit, but there seem to be differences. This is held up in other series as well. So in my own practice for L861Q, I might say, yes, we'll give osimertinib. This sounds a great thing to start with. Now, this is off-label. If the check of insurance will cover, they won't always cover because it is off-label, not approved by the FDA. But for some of the other mutations, I might say, we really probably should reach for afatinib, for example, because we've got a little more data there. So it really is on a case by case for each mutation and speaks to the importance of knowing the exact mutation when having these sorts of conversations. And these are the most common of the uncommon. So there are some even more rare ones. We don't have a lot of data. Maybe there's only a case report, or we don't even know. No one's reported anyone being treated with that mutation. And for these, we tend to look at even more detailed nitty-gritty. We try to do modeling. How does it affect the shape of the protein? Can we look what it did in a cell culture if you put tumor cells in a dish? And there is sometimes data. So we do have some things to guide us, even for some of these very rare mutations. But for those very rare mutations, I often suggest getting if you can, an academic opinion can be really helpful because they are so uncommon.
Well, thank you. That's not easy to explain, especially the common uncommon mutation.
I know.
It's like a tongue twister, right?
Yeah.
And so you pointed out a couple of the common uncommon ones and some other ones, but are there, is there research going on right now for treatment for other uncommon mutations?
Yes. So, and I think these fall into two different categories. We think about the uncommon driver mutations, the ones that are present at new diagnosis. Those often don't have a lot of clinical trials, but sometimes they do, especially if the tumor has become resistant to current available standard treatments. Maybe you've tried osimertinib or afatinib, or you've tried chemo, you're looking for something else. But there's also those acquired resistance mutations, and these are the ones that show up on treatment as part of acquired resistance to current therapies. And the one I'll highlight here, because it's the most common of the acquired resistance mutations, is this one called EGFR C797S. And this is a mutation. 797 is the number kind of in a link of all the amino acids in the protein, but the exact point in the protein that has this one change. And this happens to be the point in the protein that our current osimertinib actually binds at most strongly. So when the tumor changes that one point, osimertinib loses the point it latches onto and can't bind as well, and that helps to drive resistance. And this shows that maybe 5 to 10% of the time at acquired osimertinib resistance. And it's tough because we don't have any approved drugs that are really intended to treat this mutation. We do have some things we might be able to use. In the modern treatment, if you're getting a new diagnosis, you have your first EGFR mutation, then you get resistance, and you pick up this new EGFR C797 mutation. It's called a double mutant. And some of the older EGFR drugs, again, may work against this. So the first generation drugs don't latch on at that point. So that mutation doesn't tend to cause trouble for them binding. So drugs like the first generation gefitinib or erlotinib will sometimes use, and they can sometimes be active. So it is an option out there if you're looking for something. The real challenge comes up if you've had a series of multiple different types of EGFR drugs, and now maybe you picked up resistance mutations to a couple different drugs. So you can get what's called the triple mutation or triple mutant lung cancer, where you've got the original EGFR mutation, you've got the C797S mutation, maybe you got one of the other older drugs and you've got a resistance mutation to them. Now you've got what's called triple mutant lung cancer. And depending how these are all arranged within the tumor chromosomes, sometimes that can cause resistance to all available EGFR drugs that we have right now in the clinic, and may require things like chemotherapy or other treatments to manage. But there's a lot of interest in developing drugs that might be active against these sort of double and triple mutant situations that bind in different ways, that don't mind these different acquired mutations. These are often called fourth generation EGFR inhibitors. You'll often hear them referred to that way. And these are actively in clinical trials right now. And I think can be a really nice option to look for if you have one of these acquired multiple EGFR mutations, if you're looking to try something in a clinical trial. And just to highlight, I'm not going to go into the details to say that these are a lot of drugs in development in this space. Some of these are what's called preclinical, where they're not yet in clinical trials. And many of them are very early phase clinical trials, we call phase 1 or phase 2 trials. You can see that all of these drugs vary in what they hit. You can see there's the single mutants, the double mutants, and the triple mutants all at the top. If we go forward one more, and they vary in what they hit. So your doctors can help tell you, if they know your mutation profile, what clinical trial might be the most promising for your particular combination of gene mutations. They also differ if they try to hit other types of EGFR mutations, like the uncommon driver mutations, or things like the exon 20 insertions I mentioned before. They're all very different and specific in what they're intended to hit. And that means that one trial that might be good for one individual might not fit someone else, and vice versa. I'm just highlighting they're also different, in what we think they might do for brain metastases. Now, that's a big challenge in EGFR lung cancer, controlling obviously disease, not just in the body, but also in the brain. And sometimes we think of that as being a little more challenging to control because of the blood-brain barrier. Some drugs are known not to cross it that well. Some are thought to maybe cross it well. So if you have a need for control of brain involvement, your doctors will often look for a clinical trial, if at all possible, for a drug that's at least predicted to have some form of activity across the blood-brain barrier. So of course, we've just talked a lot about a lot of different mutations, both at initial diagnosis and during the course of treatment, but we can't make any of these decisions unless we know what the mutations are. So Balaz, I'm going to turn it over to you to talk a little bit about how we actually find these mutations at diagnosis and along the way.
Sure thing. You provided a fantastic summary of EGFR mutations. You were supposed to introduce EGFR mutations. You got us to triple mutations by the end of your discussion. So an amazing amount that you cover, but it also shows the amazing science that has gone on just for the last 2 decades. We first learned about these EGFR mutations actually just about 20 years ago. And now we're talking about 4th generation compounds, very much focused on unique types of mutations, resistance mutations, etc. And this amazing science will continue. So, just giving me goosebumps just to listen to your talk. But for us to be able to do this, we need to actually find those mutations, the single mutations, double mutations, triple mutations, all of them. How can we do that? Of course, conventionally, the best tool that we've had is using tissue, a tissue biopsy that we obtain with a needle or with surgery. And then we can look at those building blocks, the DNA or RNA building blocks, from the cell, and find these abnormalities. Well, these needle biopsies can be risky. Nobody wants to do them every couple of weeks. And as you just mentioned, Julia, nowadays we have to sample, patients' state, of how these mutations are several times. If they stayed on a drug for a while, just like if you take the same antibiotic, resistance will develop. And we need to understand how that resistance is driven, and we can. Science can tell us if there's a new mutation, just like C797S. But there could also be a bypass mechanism that you mentioned that needs to be tested in a different way. So if you could just use a blood specimen, how much easier that would be. And let me just bring it to you that those blood tests are actually available, ready to be used, and your clinician is likely using them all the time. And that goes back just about 10 years, not 20 years, 10 years ago. These were introduced into clinical practice, basically taking knowledge from, you wouldn't believe it, maternal science, discovering that the DNA of the baby can be detected in the mom's circulation, and developing those test platforms. We could use them now for patients with different types of cancer and find out that, yes, indeed, we can find pieces of tumor DNA in the circulation as well. We need incredibly sensitive technology for this, but the technology is available. These are called the NGS platforms, looking at ctDNA, also maybe easier stated liquid biopsy. Now, this technology is like really finding a needle in a haystack, because it's 0.1% of the DNA in the circulation that's typically coming from the cancer. Just think about it. And within that tiny, tiny piece, we need to understand every special mutation, these EGFR mutations, etc. So it requires very, very dedicated technology. Now that's available to your clinician, and we're so glad that we're able to use them. And we can use them both upfront when a patient gets diagnosed, with a cancer such as metastatic lung cancer, to help the doctor to find the best treatment upfront. And then we can use them from time to time to understand how the cancer has changed and adjust our treatment programs as we go along. And these are not just for EGFR mutations. These are not just for patients with EGFR mutated lung cancer. We haven't spoken about the fact that EGFR mutated lung cancer is a very important subset, but not the only one. Nowadays, we have to test for 9 different types of mutations in a patient with a new diagnosis of lung cancer, and for immune biomarkers as well, as we have better treatments from immunotherapy just as well. So a key question is, what's better, liquid versus tissue? And the reality is that these two technologies help each other out. The tissue is still needed. Your doctor still needs to make a firm diagnosis of, is it cancer? Is it lung cancer? Is it one type of lung cancer or another? But on top of that, now we need all these biomarker tests that we need to perform. And the tissue that's been obtained, maybe it's very small, maybe just not sufficient to test all the different things that you and your doctor will need to make the best decision. Many times our pulmonary doctors have these unique technologies. They take an ultrasound with the bronchoscope and take a tiny sample from a lymph node, or they take a navigational device like a GPS to drive a needle into a faraway corner of your lung. They will not take a lot of tissue because your lung might collapse. They take a small amount that might not be sufficient for everything. But this is where the blood-based test can help out the tissue biopsy. So between the two, we can have the full complement of testing. So nowadays, there's these new paradigms that are emerging. On the left-hand side, you can see the more conventional approach. Let's wait for the tissue biopsy, see if that's enough. If that's not enough, maybe send out the special liquid biopsy. But on the right-hand side, you can see the developing platforms whereby why not just send out the blood test at the same time? Because between the two, we can make sure that the testing can be the most timely and the most comprehensive as well. There's a little bit of extra, monies, that go into the dual testing, but ultimately it pays off to get the patients on the right treatment so they have the best outcomes as to cancer control, and they also have the best outcome as to minimizing side effects of unnecessary and unhelpful treatments. So more and more we take a comprehensive biomarker testing approach utilizing both sets of technologies. And we spoke about resistance as well. If the cancer progresses, well, nowadays we take the blood sample first because it's easy and it returns in just about a week. But many times that's not sufficient and the biopsy might still need to be obtained. So these tests are very complementary and they really help Julie and myself and all other clinicians globally to make the best decisions for our patients.
Let me ask a quick question before we move on. One thing that we often hear in our community, and I've experienced this myself, is, someone has had a liquid biopsy and nothing is found. Sometimes even the original EGFR mutation doesn't show up. And in that case, sometimes that person is considered a non-shedder, as in something isn't showing up in the blood. If that happens, frequently patients have to really advocate for themselves in order to say, hey, this isn't enough information. We need to get a tissue biopsy as well. How would you recommend that someone has that discussion with their doctor?
That's an excellent question. It actually takes us to our next slide because it's so important to understand what the biomarker testing has helped us learn. It's not enough just to run a test. We actually need to be able to interpret the results correctly. And just like you said, that ctDNA, that tiny amount of DNA we're trying to find in the circulation, is not in every particular patient with a cancer diagnosis. The higher the stage, the larger, the extent of the tumor burden in the body, certain size that might be involved will increase the yield. But in certain patients, an earlier stage lung cancer, for example, the shed might be very small. So we might be misinformed by thinking that the results were negative. They were misleadingly negative because they didn't contain any information. So it's very important to have a nuanced understanding of these biomarker test results to make sure that, as you can see in this slide, we can complete the biomarker testing effectively, not just within a certain time frame, not just with test A or test B, but effectively. So we have actually covered all those special biomarkers that we need to test for, both the immune biomarker called PD-L1, as well as all those special subsets of what's called molecular biomarker tests that EGFR belongs to. So again, between the tissue and the blood test, very likely that effective biomarker testing can be completed, but it's not an easy path to take, to be honest, which takes us to our next slide. Because yes, indeed, biomarker testing on paper is very easy, but for the patient, for the clinician, it can be a complicated road to make sure that we have completed it comprehensively so that the patient can be on the best path. It can take a little bit longer sometimes that we might like, but the reality is it's very important to complete this road because it will give us a much easier path forward with better outcomes, better results, knowing about the biomarker test results, and being on the best road, going forward. So, what is the technology that we can use for this? Again, this is like looking for smoke signals for the distance. We mentioned the needle in the haystack, but it's also like, you need to kind of, find all the fish in a pond. Right? If you have a, fisher, it's very difficult to do. But with NGS test, next generation sequencing test, basically you have like 100,000 fishing poles at the same time looking for the DNA from the tumor in the circulation. This is a technology that leaves no gene stranded and no patient stranded without, completing the biomarker test results. So it's very important nowadays to use these special platforms. They work both for tissue, they work both for blood to be able to do that comprehensive testing. Nowadays also in a much more timely fashion. As I mentioned, the blood ctDNA results typically return in just about a week. And if you think about it, we're talking about sequencing practically the entire genome. 10 years ago, it took 15 years and $1 billion. Now it takes 7 days. 2 tubes of blood will be spent to a special company someplace on the planet, and in 7 days, you'll get the results back. Isn't that just magical in a way?
Wait, Balaz, I have a quick question. It is magical, actually, compared to what it used to be. But what we hear a lot is that patients, how do I know if I'm getting, NGS? And really, NGS, next generation sequencing, is the same as comprehensive biomarker testing. But what would you recommend patients talk to their doctor or ask their doctor about to ensure they are getting comprehensive testing?
I think, first of all, an open conversation with your clinician or doctor is very important all the time. You need to make sure that you can have that type of a communication channel. And, there's no reason not to ask what is the special biomarker testing that has gotten performed. In fact, I might say it's very important that your doctor tells you exactly what your biomarker test results are. That is basically the most important information outside of the basic diagnosis and stage. What type of lung cancer do I have? And it's not just lung cancer, honestly speaking, any cancer type. If I have metastatic breast cancer, prostate cancer, what is the exact type I have? Nowadays, biomarker testing practically for all cancer types optimizes the treatment path going forward. Not knowing that information is a little bit like, playing ostrich and putting our head in the sand. We need to understand, what this cancer diagnosis means, what the special subtypes are, and we'll be better informed making the best decisions and being able to work with our doctors to make sure that we find the right path ahead. And the doctor is not working alone. So that's the last thing that I wanted to say here, that biomarker testing is complicated. It takes a team effort, but I'm sure that you have that team at the place where you're getting treated, and that team is working for you. That includes the pathologist, who's working on the tissue specimen. That includes the radiologist and the pulmonologist who help obtain the tissue in the right way. Ultimately, there's a molecular lab either in the hospital or someplace else working on the tissue, the DNA and the RNA to get the right information back. And your oncologist is anxiously waiting for the results to make sure that they can offer you the best guideline-driven database treatment ahead. The recommendations currently are ideally to complete this testing within 14 days. Within those 14 days, your treatment team has to run like Usain Bolt, has run the world record to be able to complete all this. But we do this all the time. We don't mind running. We love this relay to make sure that we can bring the best treatment to our patients at the point that they need it.
So there's a lot of discussion also in our group about clinical trials and what patients, it's very difficult to find a clinical trial. It's even, people who have been doing this for a while, like Ivy and myself, we have a really hard time navigating clinicaltrials.gov. So if there are clinical trials out there, what are people's options and how can people find those options?
Yeah, so, I think we always think a lot about clinical trials, especially practicing in academic centers. We do run a lot of clinical trials. And first, I'd like to comment that sometimes the standard treatment is the best treatment in that moment. Sometimes it's just the right treatment to do, either because the standard treatment is very good and we like that more than we like our trial options, or it may be because of other issues in your health that might make it hard for you to be eligible for a trial right in that minute. Or maybe just it's a really urgent, you need to start treatment fast, you need to start treatment tomorrow. There isn't time to go searching around for a clinical trial. So sometimes standard treatment is the right treatment. But it's always important, I think, to have on the list. And a great question for your doctor would be, in addition to the standard treatments, are there any clinical trials that could be a good fit right now? And how would you find out about them? And I agree, it's very hard sometimes to navigate the web of what's out there for clinical trials. Much of it is not written in a way that is intended to necessarily be patient friendly. And even as a physician, if you don't know the field well, it can be really hard to figure out what would fit well. Usually your treatment oncologist may be able to help. I think patient advocacy groups like the Resisters can be a great resource. Seeing an academic oncologist, getting a second opinion consultation at a major academic center can be a way to do that if it's feasible. And clinicaltrials.gov, we'll bring it up later as well, is sort of the clearinghouse. It's where all clinical trials open in the US are listed. So they're all listed there. I admit the website is a little hard to navigate, but if you get good at it, they're all there listed, including their trial locations and trial contacts. So there's some nice places to start. If you're thinking about a clinical trial, the first thing I'll say is there are many, many, many different types of clinical trials, and they may differ quite substantially in the experience of being on the trial, the types of treatments being evaluated, and in terms of how much we know about the potential drugs being studied. So you might see trials looking at very different strategies. They might be using existing drugs already used for one type of cancer, repurposing it in another way, might be building on a foundation of a current established treatment, adding an additional drug to it, or it might be trying to replace this established treatment, so going on something totally different from what we might usually use. They also fall in many different phases of drug development. We call them from phase 1 to phase 3 trials. And kind of a broad way to think about this is that phase 1 trials are usually earlier in development. Maybe fewer patients have been treated. There's even first in human phase 1 trials. Maybe this is the first time the drug has been in a clinical trial. And these are often very focused on understanding things like the drug safety or side effect profile, deciding what's the best possible dose of this drug, all the way up to phase 3 trials, which tend to be very, very large, often randomized trials, with maybe multiple different treatments being evaluated, often against our current standard treatment. And these, maybe the drug has already been treated to several hundred people before. Now, these lines blur a lot in oncology, especially for uncommon mutations or rare mutations, where you'll see a lot of phase 1, 1B, phase 2 trials, because it is such a small group of people who might have that mutation. So sometimes we know a lot about a drug from its function in preclinical studies, like in the laboratory, and we'll only need smaller studies to start using that drug in broader practice. And they also fall in different timing in your course of disease. There are some trials that are meant to be first-line trials, and those are treatments for people who maybe have a new diagnosis, never received any cancer therapy at all. And then there's trials that are sometimes very, very flexible that are later line trials. You could have many, many different types of treatment previously and still be eligible. And then they vary. Some only allow 1 prior treatment or 2 prior treatments. So again, sometimes places like clinicaltrials.gov will list those criteria very detailed. And sometimes it really involves reaching out to the study contacts to sort out how flexible are they in terms of enrollment. So what's it like to actually participate in a clinical trial? And this varies a little bit from trial to trial, but there are some common steps. First, you're usually being treated at a larger academic center or at a community center that does a lot of trials, and you'll be part of a broader research team where there's you in the center, you'll have your treating oncologist, you'll have your local site, then at the treating study site, you'll have your actual oncologist at the study site. And then there'll be people often on the team, like research coordinators or research nurses or the study sponsor, the person actually putting the trial on, all involved in oversight of your treatment potentially. And there's a general kind of flow through a trial where you might first start by doing a visit with the study site to talk about clinical trial options, see if it might be a good fit. It sounds like a good fit. There's a formal consent process where they'll go through the trial in some great detail. Have you actually signed what's called a written consent to participate in the trial, where we inform you as best we can what we know about the risks and benefits of the study. But then what's called screening, and this is the formal, we call eligibility evaluation. Each clinical trial has a very long checklist for criteria that try to tell us that, to the best of our knowledge, you're not at increased risk than average to participate in the study, and that you match the population of people that they're trying to study the drug in. And that's a formal thing you might go through, where over the few weeks you have some testing to sort out, are you eligible? And we often call it screening. And then if you are eligible, you'll go on to treatment on study. And during that time, you'll be treated according to the study protocol, where there's a set schedule of visits, schedule of treatments, set schedule of safety assessments, trying to essentially monitor you very closely and do the best we can to treat you as safely as possible within the trial. And trials vary quite substantially in terms of the intensity of those visits. It's an important question. If you're thinking about participating in a trial, especially if you're coming from further away, just how often do I need to be in to go to visits? How often will I need to be here to participate? And every consent form contains all that information in great detail.
And Julie, if I may just say that, it's so frightening for a patient to participate in a clinical research study, right? Am I going to be a guinea pig? And every single drug that you mentioned in your previous conversation has gone through rigorous clinical studies. And the only reason we're able to offer them today is because patients were courageous enough to participate. But fortunately, many of them actually benefited from participation. And you just mentioned all these kind of oversights to make sure that patient safety is very, very specifically assured on every clinical study. And ultimately, yes, indeed, research is basically, a window on new opportunities, hope for a better tomorrow. So, we're just so excited that we're able to provide, such options to our patients, across the globe.
Yeah, Balaz, it's a great point. And, I think a clinical trial, I think of it as a way to access potential new drugs that aren't available now yet. And I agree. We treat a lot of patients on clinical trials, and every drug starts on a trial at some point. And I think it's a very nuanced discussion, and I think we're all very upfront about the discussion. But I think for a lot of people, a clinical trial can be a good option and can sometimes be a best option.
Well, there's a lot of things for a patient to think about and talk to their clinician about if they're considering a clinical trial. Sometimes that's a little bit overwhelming for patients, because the time when you're considering that trial is right when you just found out, the news that your cancer is progressing, or even when you just, found out that you have cancer, at first diagnosis. So it's often a very stressful time for patients, and when a lot of things are going on and it's confusing. It would be great if there was a checklist or something along those lines to for patients to work with their clinicians in order to join or find a clinical trial. Does something like that exist?
Yeah, and I feel like in some ways I have a little mental checklist, right? When I'm meeting a new patient, I know they might be looking for a clinical trial, and I'm looking at our trials to sort out, is there one that might be a good fit? But the things that I would suggest is, one, all the things we just talked about, gathering the details about your cancer, knowing what your specific biomarker profile is, and talking with your treating oncologist about what they think your options are, maybe outside of a trial, if they feel a trial might fit. I think these are some examples of places to look to find a clinical trial if you are. And I think it's a little hard, because I think each center has different trials, right? So one hospital will have a certain list of trials, another hospital will have another. So there is some digging required, but the information is out there. And I think that some of these resources like advocacy centers and patient advocacy foundations can be great places to look. I will say again, seeing an academic center can also be a great place to look if feasible. I know travel is not always possible to get a sense for that. And when you are asking about a trial and trying to figure out if a trial might be a good fit for you, I'll usually say, what could you ask? You can ask things like, what do we already know about this drug? What is the, why is it being studied? How strong, what do we know about its effect against cancer cells now? You might want to ask about things like, what's the location of the study, right? one thing to go to trial in your hometown. It's another if you're traveling far away. And that's a real consideration when you're taking your time and your effort and your energy to travel a long ways. So understanding, ideally finding a trial closer to home, or thinking about, is it possible to travel? And then thinking about how intensive is the trial schedule itself? Are you just going to have to be there every few weeks or once a month? Or is it going to be multiple times a week? Or is it an infusional drug or a pill? And, what does the team know about side effects on the drug? What do we know so far? What do we know from similar drugs? And the study team should be able to help give you that information, because it's part of the trial process. If you do find a trial you might be interested in, or you think you might be interested in, usually, if you can reach out directly. The clinicaltrials.gov will always list an access person for the trial. And if you contact them, they should be able to put you in touch with study sites, and they'll usually basically set you up for a visit to talk about it, like a consultation in clinic. And there's a nice research link there as well that talks a little about questions to ask in a more organized fashion for you, and be nice to think through if you're preparing for a visit. But your doctor themselves should be able to help you navigating. I know that sounds complicated, but it's very doable with a little bit of help, is what I would say.
It is complicated, and I think that's where our community, where the EGFR Resisters patient and caregiver community can come in and help a bit. So where should you go for more information about treating uncommon mutations, and what resources are out there? And I think you could actually start with our website. We have these fact sheets on EGFR positive lung cancer, and there's 5 different ones. And if you go to our website, you can use this QR code right here. It'll take you to the page where you can download these fact sheets and look through them. And then, of course, with any questions that you have, you can reach out to one of us, or you could go directly into our closed group and ask questions. A lot of times that's where patients get a lot of information about trials, because there are other people who have participated in them. We also, on our website, we have a spreadsheet compiled by EGFR Resisters. And so this is a spreadsheet, and the disclaimer is it is not intended as any medical advice at all. It is pure volunteer efforts that people have put together this spreadsheet on different clinical trials that may be appropriate, and they're all for after progression on osimertinib. So I definitely encourage people to look at that spreadsheet. And again, contact anyone in our community if you have any more questions about that. And then we do have an article there, Understanding Clinical Trial Jargon. It's a totally different language. Oncology is completely different language, a foreign language to most of us. And so this article really will help you understand the different phrases and words that are being used, what they mean, and how they are relevant to participating in a clinical trial. And again, please feel free to reach out to us if you have any questions about that as well. So that there's a lot of information thrown at you today. And first of all, I want to thank Julia, Dr. Rotow, and Dr. Balaz halmos for really being able to articulate it in such a great way, in a way that we can better understand. It's so important that we understand the research, that we understand what these uncommon EGFR alterations are, and that we understand what type of EGFR lung cancer we have. So we really appreciate your expertise and your taking the time to spend with us today and explaining this complicated science in more of a lay terms. And also want to thank CEC, Creative Educational Concepts again, for putting this together, and of course, Black Diamond Therapeutics for an educational grant that allowed us to do this webinar. If you have any other questions, please reach out to us. We'll try our best to answer them. Thank you.